Thanks, Brittany. I hope everybody can hear me. This is the second or third one of these I've done, and I've found them to be helpful and gotten good feedback about folks who have tuned in. So hopefully you'll get something out of this. My talk will take 30 to 40 minutes, and then we'll go through questions and address any other comments, concerns afterwards. So we'll be talking about BPH. I don't think you can record audio or video. This is me. I primarily split my time between the Walker Medical Building, which is in St. Louis off Mason Road, kind of near 270 and 40. And then my other main office is over in St. Elizabeth's Hospital in O'Fallon, Illinois. I go to Parkland down in Farmington once or twice a month. I go to Sunset Hills once or twice a month, which is in South St. Louis. And then every once in a while, I go over to our Fairview Heights clinic, which is near St. Elizabeth's. Our office phone number, our office website. Like Brittany said, I went to SLU for undergrad, went to Mizzou for med school, and then I did my residency out at Mayo Clinic in Scottsdale. So we'll talk a little bit about what the prostate is, what it's supposed to do, what it ends up doing for most guys. Talk about BPH. We will not talk much about, or really at all, about prostate cancer or prostatitis, more just the typical BPH stuff. And then we'll talk about treatments, including medications and procedures. So your prostate is a gland that makes ejaculate. That's its job. So the stuff that comes out with orgasm, most of that's made in the prostate. Your prostate sits right where the bladder funnels. So your bladder is a big bag of muscle. And when you're standing there over the toilet, that bladder muscle contracts down to push the urine out of you. So urine doesn't just fall out of you. It's kind of like your heart. So it's a type of muscle called smooth muscle. So bladder squeezes down, pushes the urine out. And right where that bladder funnels, that's where your prostate lives. So in high school, prostate is about 15 to 18 grams in size. And over time, prostates get bigger and tighter and start to restrict the flow of urine out from the bladder, which makes it more difficult to urinate. So guys get obstructive symptoms, and that angers the bladder. So guys get some irritative symptoms. And we'll talk about that. And prostates can cause BPH, and we'll be talking about the first block here. Prostates can get infected or inflamed. That's called prostatitis. That can happen to any guy, young guys, old guys. Prostates can get cancer. Important to recall that cancer is different from BPH. So weak stream, some obstruction sort of stuff is not a sign of prostate cancer. So BPH stands for benign prostatic hyperplasia, basically meaning overgrowth of the prostate. BPH is a pathological diagnosis, meaning that is a problem of the prostate. The symptoms are referred to as bladder outlet obstruction, or LUTS, lower urinary tract symptoms. But generally, people just kind of say BPH, and everybody knows what you're talking about. Again, BPH is not prostate cancer. Symptoms of BPH do not mean that you have cancer. Now, you can have prostate cancer and BPH, but BPH, again, is a symptom sort of problem. Prostate cancer generally in modern times is found because PSA is going up. Whole different talk, but my 2-year-old wants to get in. Whole different talk, but PSA that's high doesn't mean there's prostate cancer. It means there could be. So we won't talk much about prostate cancer because that's a whole different conversation. But BPH and prostate cancer are separate entities. This is a picture of what that looks like, a little cartoon. Prostates can cause trouble when they're too big or too tight. And so often, generally, as prostates get bigger, symptoms get worse, but that's not universally true. I've seen guys with small prostates in retention living with catheters. But usually as prostates get bigger, the symptoms track fairly well with that. Anatomy, I get this question all the time. Your prostate's not necessarily something that wraps around the urethra. And that's a hard thing to really get your head around unless you're a urologist. But I always, when I'm talking to folks, I give them the example of your prostate's exactly like an orange. And that's the best way to think about your prostate. It's got a rind. That's called the capsule. Humans and dogs are the only species that have capsules, but you've got a rind, you've got pulp. And just like an orange has a little divot running through the middle of it, that's what you're peeing through. So you wouldn't say that the orange wraps around that little channel. It really just is part of the orange. It's just the middle part of the orange. So we call it the prostatic urethra. So it's really one thing, your prostate and the first part of your urethra. But I get that question all the time, and it's just a hard thing to get your head around. So symptoms, we generally divide any sort of urinary symptoms into two broad categories: obstructive symptoms, meaning there's something in the way, such as weak stream, hesitancy, which is you're standing there at the toilet waiting for 10, 15 seconds for it to get going, hoping it comes out, hoping tonight's not the night that you can't pee. We call that hesitancy. Intermittency, meaning there's a funny show on Netflix called the Kaminsky Method, but they referred to it as Morse code. So you pee in spurts. You pee a little bit, and you got to generate more pressure and pee a little bit more. Or some guys don't get their bladder empty when they pee. Some guys that's such a big problem that are living with catheters or cathing themselves a few times a day. So all those things are obstructive symptoms. That's fairly unique to men. Women don't have prostates. Obstructive symptoms or irritative symptoms. Irritative symptoms are a bladder problem. That bladder muscle can get angry for whatever reason. Sometimes that's caffeine, sometimes that's alcohol, sometimes that's spicy or acidic food will irritate people's bladders. Sometimes your bladder is just angry because you're obstructed. And so that back pressure can really cause the bladder to be irritable. And those symptoms are frequency and urgency. Frequency meaning you pee too much. Now, it's important to remember that you should pee probably every 3 to 4 hours is perfect. Even if you could hold your urine for 12 hours when you were in college, that's not good for your bladder. We don't like that. So every 3 to 4 hours is normal, but frequency is peeing too often. Urgency is that strong, sudden, oh my gosh, I've got to pee right now. I can't get to the bathroom fast enough, and you're peeing down your leg. That's a bladder problem, and that's oftentimes a bladder spasm. That muscle can spasm like other muscles in your body. And so irritative symptoms and obstructive symptoms. Very, very common problem. 2 out of 3 guys on Medicare, so 65 and older, 2 out of 3 take medications for their urination. 2 out of 3. About 90% of guys who are 80 take medications for their urination. And this is a significant quality of life issue. I mean, some guys are afraid to go out to dinner because they don't know where the next bathroom is going to be. So this definitely affects quality of life in a significant way. I think I just said that. So if you come into the office to a urologist, what are we going to do? Firstly, for prostate cancer screening, because again, it's a separate issue. We don't want to assume that it's all BPH if there's prostate cancer there, treated differently. But usually make sure a PSA has been checked, oftentimes by the primary care doc, but make sure a PSA is okay. We'll check your prostate. That's not a colonoscopy. Those are 2 separate things. I'm not a colon surgeon, but that's the finger wave that most guys are familiar with. So that's the digital rectal exam. We can feel the prostate to get a sense of size and more importantly, to feel for any rock hard nodules, which could be a sign of prostate cancer. But PSA and DRE, the rectal exam, or how we evaluate for make sure there's no concerns about prostate cancer. Oftentimes we'll do some sort of testing to make sure guys are getting their bladder empty. Sometimes that's a flow study. Sometimes that's urodynamics, which is a little bit more invasive, but gives us more information. Oftentimes, at minimum, we'll have you pee, empty out your bladder as best as you can in the office. And then we'll do a little handheld ultrasound over the bladder to make sure that you're getting your bladder empty. In a perfect world, you empty out your bladder completely, but you should at least get your bladder mostly empty. Otherwise, you can run into trouble with infections. Sometimes some guys will get stones in their bladder. Some guys will get pressure back up to the kidneys and kill off the kidneys. So that's one of the reasons we oftentimes will check this ultrasound over the bladder to make sure that you're getting your bladder empty. And then there's all sorts of questionnaires, which anytime you go to the doctor, we have paperwork. So what can we do about this? Firstly, we generally talk about lifestyle changes, things like cutting out bladder irritants like caffeine and alcohol, things like, if getting up at night is a problem, trying to limit your fluids for 2 or 3 hours before bed, especially things like caffeine and alcohol. Losing weight has been shown to improve urination for guys. Exercise, everything is good for your heart, diet and exercise, good for your urination as well. Most people start with pills. Don't have to, but most people start with pills, and then there are procedures. A lot of guys are on or are interested in or ask about supplements. My general thought on supplements is that if they worked as well as the medications, then they would be the medications. Pfizer would bottle up saw palmetto if it worked as well as Flomax. If you go to GNC, you'll be able to find 100 different prostate pills, Super, Beta, Prosta, Health, Max. All of them have a little bit of saw palmetto. Saw palmetto, there is some data on. So that probably helps a little bit. That's okay. Otherwise, you're probably just wasting your money. So this is, again, a symptom lifestyle sort of issue. So one thing we could do is nothing. We try to cut out liquids before bed. We try to decrease caffeine or other known dietary irritants. But as long as you're not hurting yourself, and that would mean you're not getting a bunch of bladder infections, you're not getting recurrent stones in the bladder, you're emptying out adequately, then this is a symptom thing. You don't have to do anything about this. Prostates grow over time. And so if we don't do anything, generally the problem, all it's going to do is get worse over time. Now, does that slowly get worse over 20 years? Yeah, for some people. But sometimes, in some ways, early intervention can be helpful to prevent going to the ER, needing a catheter, or treat your prostate when it's smaller, because smaller prostates are easier to treat. And we'll talk about procedures here in the next few slides. So we don't have to do anything about this. What most people do about this is, at least at the beginning, is start pills, almost always Flomax. Flomax is tamsulosin. It's an old, cheap generic pill. It's been around for decades. It's a alpha adrenergic blocker. And so what that does is essentially relax the prostate a little bit so it's not clamped down so tightly so the urine flows better. Most guys who have obstructive symptoms get a pretty significant benefit from Flomax. Flomax is tamsulosin. The other medications like Flomax are alfuzacin, which is uroxetrol, and silodosin, which is Rapaflo, but they're all basically the same thing. Side effects I caution guys on: some guys will get a little bit lightheaded when they stand up too fast. So we call that orthostasis. Worry about that in our older folks because we don't like falls. Has a reasonable chance of causing something called retrograde ejaculation, meaning with orgasm, nothing comes out. That's reversible. That's not dangerous. Weird for some guys, but that's a known side effect of tamsulosin. Some guys get a little bit of facial stuffiness, but this is generally a very well tolerated, very effective, cheap, common pill, and it's basically what we always start with. The other medication that that tamsulosin is commonly paired with is something like finasteride or dutasteride. These work by shrinking the prostate. They take 6-ish months to work because it takes a while to shrink the prostate. Finasteride is the only pill that's been shown to decrease the chance that a guy completely blocks up and has to go get a catheter put in the ER. It also decreases the chance that we do procedures on folks. So even though it's against my financial self-interest, I'm a big fan of finasteride, especially for bigger prostates. Old, cheap, common generic pill, the exact same medication in Propecia, which a lot of guys take for hair loss. A lot of young guys take for hair loss, same drug. About 5 to 8% of guys on finasteride or dutasteride will have some sexual side effects, like less interest in sex, maybe some erection problems, less ejaculate volume. Some guys will get some breast tenderness. But most guys tolerate this well. Good, common pill. Our studies, the data says that the absolute best medical therapy we have for BPH is the combination of tamsulosin and finasteride together. The other medication that's not on here that is used for BPH is daily Cialis. Tadalafil is the generic for that. Cialis has gone generic. It's obviously an erection pill, Cialis, but in a low daily dose that helps with urination. So a lot of guys with a little, it's not as good as tamsulosin or finasteride, but a lot of guys, especially younger guys with a little bit of trouble with urination, a little bit of trouble with erections, that daily tadalafil is a pretty good thing. So those are the 3 pills we use: alpha blockers like tamsulosin, 5-alpha reductase inhibitors like finasteride, and then ED pills like tadalafil. In terms of procedures, we got a lot of things we can do to prostates. They're all meant to open up the channel and get the urine flowing better. Resume is something I'm a pretty big fan of. Resume is something that's done in the office. There's no general anesthetic. Drive yourself home if you want. We use a lot of local anesthetic. Guys do very well with this. It's uncomfortable. There's no way around that, but it's not a real painful thing. And honestly, guys do fine. In our office, we have a nitrous machine. So that's like the laughing gas you get at the dentist office. So some guys choose to do that. I think it's another $100 or something, but most guys do fine without it. They're done in the office. We numb everything up. We put a scope in, and into that chunky prostate tissue, we deploy a needle that delivers hot steam over 9 seconds into the pulp of that orange. And basically that desiccates the orange. Depending on the size of the prostate, we do this somewhere between 4 and 10 times, all during the same day, the same session. But I like to treat the left side a few times, the right side a few times. Each treatment again takes 9 seconds. You got a catheter for somewhere around 5 days afterwards. That's annoying, not the end of the world, it's temporary. Symptoms get better over the few weeks after the procedure. 5-year retreatment rate is less than 5%. Other way of saying that is 5 years after a resume, 19 out of 20 guys do not need another procedure done. Main reason I like it is because there's no risk of anesthesia, and this basically has no long-term side effects. At the beginning, as you're healing, things aren't perfect, but that's temporary and goes away. But there's no permanent implants. There's essentially no risk of the procedure, which is nice if your prostate is sized and shaped well for it. I don't think that you can hear this, I'm told. I don't know how to make you hear it. Let me see what's helpful. So again, cartoon of the prostate. We put a scope in, we got a monitor. You can see the screen if you're interested. Some guys like that, some guys don't. We deploy a needle into that tissue, and that delivers hot steam over 9 seconds. And that causes that chunky obstructing prostate tissue, the pulp of the orange, basically to shrivel up. What happens is those parts of the prostate die, and your body just reabsorbs them over a few weeks. So that destroys tissue. Thumbs up means there's basically no side effects. There's 0% sexual dysfunction. You don't need anesthesia, which I mentioned. Usually, in terms of recovery, I kind of like guys to take 2 weeks of taking it easy. Don't have to be bed bound. I mean, walking's fine, stairs are fine. Just basically not going to the gym, playing golf, just for a couple weeks or so. This is FDA approved for prostates between 30 and 80 grams. It has great data that it's great for bigger prostates than that, but it's not covered. I've done it on bigger prostates. It works well. I think our cash price, if it's not covered, but the guy really wants it, is somewhere around $2,500. And again, there's data on it, but it's only approved for prostates up to 80 grams. I don't know that you're going to be able to hear this. Brittany, text me if you can hear this. All right, you can't hear this. The guy's happy with his resume. Urolift is another minimally invasive procedure that's commonly done. Most guys have heard of this. They do more TV advertising. I mean, there are commercials on the Super Bowl, but I get asked about Urolift probably more than resume. Urolift, we essentially go in and staple the channel open. So this does use permanent implants. They're studied, they're safe, they're MRI compatible. They're not going to set off the security at the airport. One of my partners does these in the office, actually. Most of us use a little bit of sedation, like a colonoscopy, so some propofol. It takes 5 to 10 minutes, and we, again, just move that prostate tissue out of the way. I think this works best for smaller prostates, so 30 to 50 grams or so, just because there's not that much obstructing tissue. But if you got a 50-gram prostate before Urolift, you're going to have 50 grams of prostate afterwards. It's going to be moved out of the way. So stream generally improves pretty quickly, but the retreatment rate, it's starting to creep up there. At 5 years, about 15%. Real world studies say more like 20 to 25%. I do Urolift. I tend to favor resume a little bit, especially for bigger prostates, but smaller prostates, I think, respond really well to Urolift. Again, zero sexual dysfunction with Urolift and resume, both very easy outpatient or office-based procedures. Green light, photovaporization of the prostate. I don't do this. I have found personally that irritative symptoms, so that urgency and frequency, those can get worse after this, and sometimes that doesn't go away. A green light, basically, you go to sleep, general anesthesia in a hospital, scope goes in, we aim a laser at that tissue and vaporize it, essentially. So more like real surgery, because you do have to go to the hospital under general anesthesia. Generally very, very well tolerated in terms of post-op stuff. retrograde ejaculation, which we mentioned with tamsulosin, that can be permanent after this. Some guys get a little bit of scar tissue. Again, the reason I don't do it is because the urgency, I've seen that get worse and not get better long term after this. And I think there's better, easier ways to treat prostates than a green light, but commonly done. A lot of my partners do it and love it. So not a bad procedure. It's just something that I personally don't haven't really had good outcomes with. I know you can't hear this, but if I recall right, so I think there's a nice animation here. So scope goes in, and with a green light, use a laser and basically just vaporize the pulp of that orange out, and that opens up the channel. So carve open a channel to give more room for that urine to come out in a nice, good, strong stream like it used to. All of the procedures basically are aimed to accomplish this same thing. There's just different ways to skin a cat, and green light's one of them. And then again, this is kind of a comparison. We've seen this before, but before we do a procedure like a green light or resume or urolift, you're peeing through all this pulp. Again, think about the prostate like an orange. Afterwards, nice open channel, streams better, prostate is open and bladder's happier. TURP has been done since the 1800s. This is the gold standard, done in a hospital, general anesthetic. Most people stay overnight. I'll sometimes send guys home the same day for smaller prostates, but scope goes in, we use a hot wire loop, and we just carve out that tissue. So we actually remove, during the procedure, we remove a lot of that prostate. Recovery with any of these, you can have a little bit of burning, stinging blood for a few weeks. That's true sometimes, even just when you have a catheter come in. But specifically with TURP, very low risk, but real risk of causing trouble with erections. It's a 1% or 2%, which you don't have with resume or urolift. Again, will cause retrograde ejaculation, so no more stuff with orgasm. And I've definitely seen a couple strictures, which is scar tissue after a TURP, especially for smaller prostates. Lifetime retreatment on a TURP's 5 to 10%. This has actually been compared to some of the more minimal procedures. Flow rates improve more with a TURP. So objectively, urine comes out in a stronger stream after a TURP compared to a resume or urolift. But symptom-wise, doesn't really seem to be much of a difference. In other words, resume and urolift, when we do those questionnaires that we make you all fill out in the paperwork before you see us, symptoms seem to improve as much with a resume or urolift as with a TURP, which is a reason a lot of guys like these other minimal procedures, because if you can feel like you're peeing just as well, then why have a TURP? But still one of the most commonly performed urologic BPH procedures in the world, done all the time. It's good surgery. Prostatectomy, simple prostatectomy, is done in places that don't have somebody that does a HOLEP. I do HOLEP, which is holmium laser enucleation of the prostate. So really nobody in St. Louis should be getting a simple prostatectomy, but a HOLEP is scope goes in, still all done through the urethra. And instead of pushing the pulp out of the way or steaming it or carving it, I enucleate it, meaning if you think about an orange, just like if you got your finger in between the pulp and the rind, you shell out all the pulp, that's a HOLEP. So flow rates improve overwhelmingly. I've had guys tell me if their house were on fire, they could put it out. Lifetime retreatment rate is less than 1%, but in a hospital, general anesthesia, and the channel's so open after a HOLEP that guys leak at the beginning, and that goes away, but it can take weeks to months. So generally, guys who are getting a HOLEP are huge prostates living with catheters, or they want one thing for the rest of their life and never have to think about it again. So those are the 4 procedures that I talk about, because I don't think there's a prostate out there that I can't treat with a resume, a Urolift, a TURP, or a HOLA. But certainly there are other things out there. Aquablation is a new thing that might prove to be good, but it hasn't yet. Green light, like I said, a lot of my partners do. I haven't found it to be helpful in my armamentarium. And then there's a couple other things that are less commonly done. These things have certain criteria. So like I said, Resume between 30 and 80 grams, Urolift between 30 and 100 grams. Whenever we schedule a surgery, our schedulers authorize all that. As long as you're doing the right procedure for the right prostate for the right reason, insurance is going to cover all this stuff. So we talked a little bit about what the prostate is, what's it supposed to do, what can it do. Talked about BPH symptoms, common stuff, and all the options, including doing nothing, to the available medications, to the quick outpatient easy procedures, to the more invasive but probably more effective surgical procedures. So, you know, I see BPH folks all the time, do prostate surgeries all the time. Most urologists do. So I'm happy to see you, and my partners is happy to see you. But primary care docs oftentimes, once it gets beyond the, hey, here's some Flomax, try this. If that doesn't just fix it, then generally they'll send you over to a urologist, because this is our sort of field. So that's my talk. I'm happy to see what questions Brittany can scrounge up and answer them if I can.